Hi all, my name is Dr. Ashley Clark, and I'm going to be talking about the daily grind, or from benign to malignant, practical oral pathology for your practice. I am the division chief and laboratory director at the University of Kentucky College of Dentistry, where I'm currently an associate professor. So conflicts of interest and disclaimers. Perel Pharma is covering my honorarium for this talk, so I want to shout out Perel Pharma. The opinions expressed in this presentation are mine, not those of my employer, and these opinions should not be construed as advice for specific patients. Okay, so that all being said, let's just jump right into it. Today, we're going to talk about common lesions of the oral cavity, determine which lesions should be viewed as potentially malignant, and talk a little bit about how to manage these patients that sit in your chair that have oral pathology. So this is geared toward the general dentist. So if there are any specialists with any specific questions, I'm going to give you my email address at the end. I should say general dentists and hygienists as well, and assistants, because a lot of the times the auxiliary staff picks up on a lot of these things. Anyway, so outline of topics. We're going to talk about infections such as herpes and candidiasis. We're going to talk about aphthous ulcerations and then some epithelial lesions. And I usually talk about maybe 3 things per hour, so I'm going to be hitting a lot of topics here. So I want to give you kind of what you need to know when this hits your chair. So we'll first start with infections. So we'll talk about herpes and candidiasis. So if you know me at all, you know that I really enjoy talking about the herpes virus. I find it to be a fascinating virus. And so my students bought me, some of my former students from University of Texas at Houston bought me these giant cold sore dolls, and they're still in my office to this day. So, pardon me, just an intro. We typically think of herpes simplex virus as HSV1 and HSV2. So simplex 1 is above the waist, simplex 2 is below the waist. However, there was a study done in 2003, or it was published in 2003, and these researchers followed college students for 9 years, and over 75% of new genital herpes infections are actually caused by type 1. So type 1 is the most prevalent virus above and below the waist. Below the waist lesions, anywhere from 16 to 20% of the population is affected by genital herpes, but that's only based on simplex 2 seroprevalence, meaning there's a lot more people that are suffering with genital herpes. The whole point of this slide is to say that it doesn't really matter if it's type 1 or type 2. The lesions are the same. Type 1 and type 2 can go wherever they want. It's just that type 1 prefers above the waist and is now sort of the predominant virus. And this virus is pretty ubiquitous. So almost everyone has been infected with herpes simplex virus, regardless if they've ever had a lesion or not. So let's talk about the primary infection. Now, the primary infection only shows itself clinically in 10 to 20% of patients, meaning most patients who have been infected with herpes simplex virus have no idea. They never had these lesions. But if you're part of that cohort that does have a clinical presentation, the most common way it presents is called acute herpetic gingivostomatitis. So there will be an abrupt onset, and this will be accompanied by constitutional symptoms such as fever, malaise, anorexia, and the patient just won't feel good. And then what happens is numerous pinhead vesicles appear. They collapse rapidly and they form small red lesions which ulcerate and then coalesce. In primary herpes, both movable and attached oral mucosa can be affected in health. This is not the case with recurrences, so I like to point that out. In every case of primary herpetic gingivostomatitis, the gingiva will be involved. So they're enlarged, they're red, and they're painful. Something that I like to look for in the gingiva are these punched out erosions of the mid-facial free gingival margins. For me, that's a very helpful clue. Like, okay, I think this is primary herpes. Let me find one of these punched out lesions. There it is. That definitely makes me feel 100% about my diagnosis. And I'll show you pictures. So the vermilion and perioral skin may be involved, and you have to watch because the age range of people who get primary herpes is typically between the ages of 6 months and 5 years old. And these patients might put their fingers in their mouth and spread the herpes to any cuts they have on their fingers. They can then spread it to their eyes or genitals. So you sort of have to watch if it's a young patient that has these lesions because they can self-inoculate. And then all cases will resolve in 1 to 2 weeks. Even really severe cases will be gone in a couple of weeks. I also want to point out, I know this is a lot of text on a slide, and that's sort of, anti-PowerPoint 101. You're not meant to put this many words on a slide, but I like to, so you can have every bit of information with you with the handout. So I just wanted to explain why my slides are wordy, and it's so you don't really have to take notes. I just wanted to give you all the information. Okay, so here is an example of this punched out lesion of the mid-facial free gingival margin that I was telling you about. So you can appreciate the gingiva are enlarged and they're red, and the patient will be in pain. But then you can also see these sort of punched out areas that helps us nail our diagnosis. Here's another example in a younger person. So you can appreciate these sort of gingival lesions. You do get some materia alba because it's hard to brush here. So you might get like a little bit of plaque-like white lesions. Here you can appreciate these big ulcers on the palate. And then there's some on the dorsal tongue and some on the buccal mucosa. So this is another example of primary herpes. It's a really severe case I wanted to show you. You can see some crusting of the lips and then these sort of defined lesions of the lower labial mucosa. Pardon me. And then, of course, the gingiva are always affected in primary herpetic gingivostomatitis. This patient's tongue was also diffusely affected. But again, even in a couple of weeks, this will all be cleared up. This is one of my patients. She was 16 years old. This was the initial photo that I got, and my differential diagnosis at this time, not being able to see the gingiva, was erythema multiforme, or herpes, primary herpes. So erythema multiforme or multiforme will present with sort of hemorrhagic crusting of the lips. However, it typically spares the gingiva. So here's the patient. By the time she got to my chair, the gingiva are diffusely affected. This is the best picture I could get. I tried several times, but she was in a lot of pain. But you can see the ulcers of the lower lip have sort of defined themselves. So now the diagnosis is pretty easy that this is primary herpes. And again, here's a nice example of that material that you can sometimes find on the gingiva, because it's hard to brush because the patients are in pain. So the next thing we'll talk about is the recurrence. So the most common site of recurrence is the vermilion border. It's called herpes labialis. I personally like to say cold sore or fever blister rather than the H word. And that's just because I've had experience from angry patients. I'll put it like that. So I like to call these cold sores. So 40% of your patients will have a history of cold sores. The majority will have 2 per year. most know when they're coming on. So they'll have a prodrome of itching or tingling or pain about a day, anywhere from 8 to 24 hours before the lesion appears. These lesions are multiple small reddish papules. And what happens is they form clusters of fluid-filled vesicles. The vesicles rupture and crust over. And when that happens, active viral replication is complete. That's important because if you have a patient with intact vesicles, you should not treat the patient that day, because if you burst the vesicle, the virus can be released and spread. And I'm actually not so worried about it spreading to you because you've got your PPE on, right? I'm actually more worried about the patient spreading it to like their own eye. So the rule is if they have intact vesicles, that means active viral replication is happening, and we need to defer treatment until they have crusted over. And then lesions will heal without scarring in about a week. And someone asked, is there any odor associated with this? And the answer is typically not. That's not something we usually see with recurrent herpes simplex. Now with necrotizing ulcerative gingivitis that affects the gingiva, that will have an odor. So sometimes that's in our differential diagnosis, not really here though with all these lesions. But usually herpes doesn't have an odor. So here are some examples of herpes labialis, so you can appreciate these intact vesicles. I would not treat this patient that day. Another example of a patient with intact vesicles. This patient actually was treated by the dentist, and all of these vesicles burst. So the dentist was very lucky that this patient didn't spread it to either herself or someone else. I like to show these together because these are intact vesicles and I would not treat this patient. But by this time, the lesions have all crusted over. Active viral replication is complete, and I would treat this patient even though it looks pretty gnarly. So like I say, I usually don't say herpes, it's a cold sore. And the etiology, typically human herpes virus type 1, occasionally human herpes virus type 2, but it doesn't really matter. They're both pretty much the same virus. So intraoral lesions. Let's talk about ulcers on the inside of the oral cavity. In health, they are always on keratinized bound mucosa, so hard palate, attached gingiva. If proven on movable mucosa, you have to get immune status tests, meaning if a patient has a recurrent cold sore or recurrent herpes on the buccal mucosa, that patient usually either has AIDS or cancer. So healthy patients just don't get herpes on movable mucosa. Hard palate, attached gingiva, that's okay. So the intraoral lesions are typically not symptomatic, and usually patients won't even know that they have it. The lesions start as 1 to 3 millimeter vesicles, which rapidly collapse to form this sort of red macule. They coalesce and enlarge, and then the damaged epithelium is lost and the ulcer appears. These lesions heal without scarring within about a week. I was asked how common is herpetic whitlow, and that used to be very common in the time before dentists wore gloves. Dentists were the #1 profession with herpetic whitlow, that's herpes of the finger, but we don't really see that anymore. So here is recurrent herpetic lesions, and then 1 week later, they're totally clear. So also shout out to Dr. Martinez for these photos, and Dr. Neville for these photos. All of my photo credits are at the bottom. So here's a cluster of ulcers, hard palate. So we know it's not aphthous ulcers, it's herpetic ulcers or trauma. So the differential diagnosis here is a traumatic ulcer or a herpetic ulcer. So someone's asking, What about the buccal mucosa? I've had one there recently, or I had a patient with herpetic lesion on the buccal mucosa. Well, it might have been trauma, or it might have been an aphthous ulcer, and we'll talk about that in a minute. So here are some ulcers that are coalescing. And now for treatment. There are other treatments that you can use for herpes. I just wanted to give one example, so you had something in your back pocket. So for primary herpes, you do want to give a liquid. You don't want to give a tablet. It doesn't work as well. And the suspension is 15 milligrams per kilogram, and that's up to a maximum of 200. The patient will rinse and swallow with that for 5 times a day for 5 days. For recurrences, you can use valsiclovir or acyclovir. And this is a really nice practice builder because 40% of your patients get cold sores. So you can say, hey, do you want a medication that will help prevent these? And if they do come, they don't last a full week. They last just a couple of days. And your patients will really like that. So you can prescribe them 2 grams of valsiclovir, or excuse me, 4 grams, and tell them to take 2 at prodrome and 2 12 hours later. This says 2 hours later. That is a typo I'm going to fix right now. So 2 grams 12 hours later. Or acyclovir. Sometimes insurance doesn't want to pay for valsiclovir, so they prefer the patient take acyclovir. Works exactly the same. It just doesn't have the bioavailability that valsiclovir has, so the dosing is less convenient. So for acyclovir, it's 400 milligrams 5 times a day for 5 days. If recurrences are associated with dental procedures, you can take 2 grams valsiclovir twice a day on the procedure, 1 gram the following day. If you have a patient that says, hey, doc, I'm going on a cruise and I know that I get a cold sore whenever I go on these cruises, is there anything you can do for me? You can give a short-term prophylactic, acyclovir 400 milligrams BID or valsiclovir 1 gram daily. I'm getting a lot of questions. I'm going to hold them until I get to the end, if you don't mind. Just a couple, any evidence that L-lysine can prevent outbreaks, anecdotal, but not proven in the literature, but anecdotal, yes. Can we see primary herpes in older patients? The answer is yes. The oldest patient I've seen has been about 28. Can you get recurrent lesions on the tongue? I do like to avoid talking about that in general. Herpes on the tongue is not a good sign. Those are usually traumatic or aphthous ulcers. So moving on to candidiasis, the best recognized form is thrush pseudomembranous candidiasis that you all know. I don't need to spend a lot of time on this. These are removable white plaques. And for the sort of newer dentists in the audience or newer hygienists, you do have to put a little bit of pressure to remove those plaques because yeast has burrowed into the tissue. So you can't be very gentle and remove them. It does take a little bit of pressure. And the underlying mucosa might be normal or red. So here's pseudomembranous candidiasis. These will be removable. And here's before and after removing the candidiasis. Now, erythematous candidiasis, I want to talk a little bit more about. So it's more common than pseudomembranous candidiasis, but it's usually overlooked. So there are several clinical presentations, and I'll go through each one. Median rhomboid glossitis, that is a well-demarcated red zone. It affects the midline, posterior dorsal tongue, just anterior to the circumvallate papilla. It is asymptomatic and symmetrical. We also have chronic multifocal candidiasis. So that is a patient with median rhomboid glossitis plus another site. And that might be a kissing lesion on the palate. It's a red lesion of the junction of the hard and soft palate. So if you see that red lesion on the palate, that's typically what you'll notice first. Just look down at the tongue and see if there's a red lesion there. Or patients might have median rhomboid glossitis with angular cheilitis. And angular cheilitis is Redness, fissuring, or scaling at the corners of the mouth. It is most commonly noted in older edentulous patients that aren't wearing their denture, so they're losing their vertical dimension of occlusion. And saliva pools in the corners of their mouth, and then they get this sort of infection of either fungus, bacteria, or both. Denture stomatitis happens in people who are wearing dentures, and the tissue will be bright red under a removable denture. And the denture harbors the organism, so that's really what we have to treat is the denture. And lastly, under this sort of umbrella of erythematous candidiasis is acute atrophic candidiasis, or antibiotic sore mouth. Now, this will follow a course of broad spectrum antibiotics. The mouth will feel scalded, and there will be a diffuse loss of papilla. You have to remember to ask patients who present like this if they took antibiotics, because 9 times out of 10 patients who present like this just have xerostomia. So you want to rule out a fungal infection. And I admit, I forget sometimes too, when patients come to see me for dry mouth and they're having these symptoms, I occasionally will forget to ask them if they took broad spectrum antibiotics, but that's really the most appropriate thing to do to ensure they don't have acute atrophic candidiasis. Here is an example of erythematous candidiasis, median rhomboid glossitis. And then this is the same patient with a kissing lesion of the palate. So this patient actually has chronic multifocal candidiasis. Here is angular cheilitis, and I would wager that 100% of you have a patient in your office right now who has angular cheilitis. It's very easy to overlook, and patients typically won't complain about it. I had this for several years, so I might be particularly sensitive to it because it's kind of unsightly. So I always look for angular cheilitis just because I want to help get rid of that look for patients. Now, this is a patient with angular cheilitis, but it's very severe. And if you look in their mouth, you can see sort of a glossitis, it looks inflamed and red and raw. So this patient should be evaluated for an iron deficiency if it gets this severe. Here's a really wonderful example Dr. Bhattacharya, Dr. Cohen, and Dr. Islam from UF let me use. So this is before the denture is taken out and after the denture is taken out. So totally asymptomatic patient, but bright red tissue. And this is denture stomatitis. Antibiotic sore mouth. This looks just like a xerostomach patient, and this is before and after treatment. Here are treatments for candidiasis. Now, most of you probably prescribe nystatin, which is why the example I gave to prescribe was something else, just so you have something else in your back pocket. I use clotrimazole 10 milligram troches. I give 70 of them and have them dissolve one on their tongue 5 times a day for 14 days. I make sure to emphasize to finish all medication. I think about 90% of patients in my practice that come to me and they've been prescribed clotrimazole are taking it improperly. So they're just taking it when their tongue burns and stopping when the tongue stops burning, or they're not taking it 5 times a day, or something like that. So the number one reason that it doesn't work is because it's not being used properly. And I have to say, I don't really blame the patient for that, because it would be really hard for even me to take 70 pills over the course of 2 weeks. So if you have a compliant patient who can take the medication, you can give fluconazole 100 milligrams. You give 15 pills. They take 2 on the first day and 1 every day thereafter. But you do have to make sure the patient can take that medication because there are multiple contraindications and medication side effects. The best thing for angular cheilitis is to, number one, have the patient throw away whatever it is they're putting on there. most patients are using like an Aquaphor or a Vaseline and putting it on the corners of their lips to soothe it. But all that's doing is sealing in the organism. So have them throw away the tube of Aquaphor, then have them buy clotrimazole over-the-counter cream. That class of medication has antibacterial properties as well as antifungal properties. And remember, 60% of the time, angular cheilitis is caused by both. So have them put that cream on there 4 times a day, once after each meal, once before bed. Then if they want to buy a new tube of Aquaphor, they can put it on after they put this clotrimazole cream on. And then, of course, you have to clean the denture if your patient has denture stomatitis. Next up is aphthous ulcers. So the person who asked about the buccal mucosa lesion, see if this better describes what your patient had or what you had. And if not, go ahead and put another question in the chat. So aphthous ulcerations, 20% of your patients will have this. So we've already talked about herpes, that's 40%. A great number of your patients currently have candidiasis, probably erythematous candidiasis. And about 20% of your patients will suffer from aphthous ulcerations. So what causes aphthous ulcerations? A variety of things. The most common, number 1, sodium lauryl sulfate found in toothpaste. Number 2, medications. Number 3, foods. And the food list is so long, I just included some common ones. Another thing that can lead to aphthous ulcers is smoking cessation. So I've had patients say, hey, I stopped smoking, now I'm getting all these ulcers. What's up with that? And the answer is, if you are a person who smokes, your oral mucosa thickens a little bit to try to protect itself from the chemicals. And once you stop smoking, the mucosa thins back down. Thinner mucosa ulcerates more easily. So you might have to explain that to your patients. Aphthous ulcerations exclusively occur on movable mucosa with very rare exception. So buccal mucosa, unattached gingiva, labial mucosa, soft palate, etc. These are more common in younger patients. And in fact, 80% of patients with aphthous ulcers get their first ulcer before they're 30. If they are older than 30 and they all of a sudden start getting aphthous ulcers, that patient needs to be evaluated for a systemic condition. The ulcers have a removable yellowish membrane and then a surrounding red halo. I recommend do not remove this membrane. It hurts very badly, speaking from experience. When I got into path school, I decided to remove, I get ulcers myself. So I decided to remove mine to see what happened. And the answer was pain. Pain happened. So I recommend don't remove it on your patients. So for the minor form of aphthous ulcers, patients will get ulcers every few days to every few years. I personally had ulcers, I would say once or twice a week. The ulcers will be around the size of a pencil eraser. They will heal without scarring in a week or 2. And patients will get 1 to multiple lesions per episode. So those are minor ulcers. For major ulcers, they're big. They can get up to 3 centimeters in diameter. They take a long time to heal, sometimes up to 6 weeks. And when they do heal, they can scar down. And again, either 1 lesion or multiple per episode. The major aphthous ulcers prefer to live on the labial mucosa and then in the back part of the oral cavity, but that's not a hard, fast rule. Here is an example of a minor aphthous ulcer. You can all recognize this. This will be painful. It's got this removable membrane with surrounding red halo. This is actually me. So I don't know why I did not put gloves on. I knew I was going to have to explain that this was me. I'm sorry about that, but this is an aphthous ulcer that I got. So you can appreciate this removable fibrinopurulent membrane surrounded by a red halo on the labial mucosa. Here is probably a major aphthous ulcer. So you might get scared about cancer because of the location. So what I would do is, number one, ask the patient, do they often get these? Number two, if the patient's in pain, that's a pretty good indication they know how long it's been there. You know, it's only been there for a week. Number three, it's surrounded by this red halo. Number four, it won't be indurated or it won't feel hard, although it probably be pretty hard to palpate this one. So if you're worried, you can recall this patient in a couple weeks to ensure the lesion is gone. And I love showing this photo of an aphthous ulcer because it's on the unattached gingiva. And if you would take this ulcer and put it down here, then our differential diagnosis is trauma and herpes. But since it's right here, it's an aphthous ulcer. And this is actually Dr. Jerry Boco's picture. So shout out to Dr. Boco. So we can diagnose aphthous ulcers based on looking at them and asking the patients a couple questions. Patients who have complex ulcers, you know, they're older, they're getting major ulcers, they're never going away, should be evaluated for systemic conditions. So I have refer here because that's really beyond the scope of this lecture, because about 60% will have an associated deficiency or disease. And things in my practice, I rule out not just Crohn or Behçet, but also Magic syndrome, PFAPA syndrome, Sweet syndrome. There's all sorts of things that can cause aphthous appearing lesions in the oral cavity. So here is the treatment. Number one, I switched to SLS-free toothpaste. My personal favorite is Squiggle. It does not have SLS. It doesn't have irritating flavors, no tartar control agents. The rate determining step is you have to buy it online. Biotin is probably the easiest to recommend because there are only two types. Both types are SLS free. You can find it pretty readily. Sensodyne is made by the same company, and it's probably easier to find Sensodyne. But the problem with Sensodyne is there are 21 types of Sensodyne, and not all of them are SLS free. So your patient will have to read the ingredients to ensure it's SLS free. Patients with minor aphthous ulcers can be treated with over-the-counter care like Orabase. If you want, you can prescribe a magic mouthwash for pain. So the most common formulation is diphenhydramine with liquid Maalox plus or minus viscous lidocaine. I find in my patient population, number one, this magic mouthwash sometimes can cost like $180, which is ridiculous. So I just have them, and number two, they don't want their whole mouth numb. So I just have them mix equal parts diphenhydramine and Maalox and use that. If it's a really severe case, you can give the patient topical steroids. Most other active treatments have not been examined in a double-blind, placebo-controlled fashion. So that's why this is my treatment slide, but I do want to acknowledge that Aphthosol works just fine. Laser ablation can work. It's probably impractical because I personally couldn't run to the dentist every time I had an aphthous ulcer back when I was getting them. My ulcers are pretty well controlled with SLS-free toothpaste. I now get them maybe once a month instead of once or twice a week. Dibacterol can be used, but you have to be careful so you don't lead to tissue necrosis, but absolutely that can be used. Someone asked me about that. I would recommend against cautery with silver nitrate. This is a patient of mine that had major aphthous ulcers. I wanted to show you the before and after. He had not gone without an ulcer in his mouth for about 30 years, he told me. All I did was switch him to Squiggle toothpaste. I gave him a magic mouthwash and I gave him a steroid. And this is the before and after. And it's just 3 weeks time I gave it. So still not completely healed, but you'll note, or I'll tell you, no new lesions. So I was able to successfully manage this patient who had been suffering for 30 years, had finished, been to 12 different clinicians. All I had to do was switch his toothpaste and give him a steroid. So hopefully that's of use to you and you can use that in your practice. I'm sorry, someone's asking, what does SLS stand for? It stands for sodium lauryl sulfate or sodium laureth sulfate. There are a variety of treatments that dentists have used other than Apthys. I just can't get into all of them. One used etch, that will cauterize the area. One would blow out a match and cauterize his own. So everybody, it's my most popular commented, hey, I use this for treatment. So there are many other treatments that I just personally gave you what I use. Next, we have epithelial lesions. So I'm going to cover, this is the last part I'm going to cover. I know I'm talking so fast, so I hope that it's not distracting. I just want to make sure you get as much path as humanly possible. And also I really like pathology and I get a little excited, but I will be mindful and try to slow down. So pigmented lesions. Our main differential diagnosis for a pigmented lesion: amalgam tattoo, melanotic macule, melanocytic nevus, and melanoma. So anytime you have a solitary pigmented lesion in the oral cavity, either a person of color or a white person, by the way, I was taught that for white people, we have to biopsy, but I recommend a solitary pigmented lesion be biopsied in all patients if there's no amalgam. But anyway, so any patient, solitary pigmented lesion, 4 simple steps. Number 1, if appropriate, take an x-ray. So if it's on the gingiva, take an x-ray. Number 2, examine the x-ray. If you see a radio opacity, you're done. No biopsy required. That's an amalgam tattoo. We have our diagnosis. Step 3, if we do not see a radio opacity, biopsy is required. The only exception to that is a labial melanotic macule, and that's because the patient will know that they've had it forever and then it isn't changing. But if it's in the oral cavity, we must biopsy if we can't prove it's an amalgam tattoo. The only purpose of the biopsy is to rule out melanoma. Mucosal melanomas have a horrible prognosis and they present at this really advanced state, and it's really an awful diagnosis. So that's what we're trying to do, is catch melanoma as early as possible. If it isn't melanoma, no further action required unless there's a clinical change. And that is the only slide I have on pigmented lesions, because that's all you need to know about pigmented lesions. Look for amalgam. If you can't find it, biopsy it. Or refer for biopsy to perio or surgery or whomever does your biopsies. This was a patient sent to me. She was 15 years old. We have this fairly large lesion, and the clinician sent me these radiographs, but these were so small, the clinician wanted a second opinion. But this is how small the amalgam will be sometimes. And even this tiny amount of amalgam can cause this huge lesion. So 9 times out of 10, even if it is an amalgam tattoo, you might not find amalgam on the radiograph. So here's an example of a labial melanotic macule. The patient can see it, they can verify it hasn't been changing. This one we don't have to biopsy, but all the other ones we do, and I'll show you why. So here is a melanotic macule, and here is mucosal melanoma. This is an acquired melanocytic nevus. This is mucosal melanoma. This is melanoma. So anytime you have a solitary pigmented lesion, it's got to be biopsied. So another melanoma. Papillary lesions. All papillary lesions need a biopsy. And let me go through our main differential diagnosis. It's squamous papilloma, verruca vulgaris, and condyloma acuminatum. Some thoughts about squamous papilloma. They're very common. 1 in 250 of your patients have one. They are solitary because they're not very infectious. So there's typically one lesion. Squamous papillomas are not sexually transmitted. They do not put the patient at risk for HPV-driven squamous cell carcinoma. There's no malignant potential and no further action after diagnosis. So simply put, my son is 6 years old. If he had a squamous papilloma, I would not worry about it at all. Next is, I have 2 sons. I don't know why I always use the 6-year-old. If my 3-year-old had it as well, I wouldn't worry about it. But anyway, so verruca vulgaris, also not sexually transmitted, but it is pretty infectious. So it spreads really easily. So the patient might have multiple lesions. There is no malignant potential because this is another name for the common wart. And the treatment is to follow up in case the patient has recurrences. The condyloma acuminatum is a sexually transmitted infection. I'm writing disease here, but the proper term is STI now, sexually transmitted infection. It's infectious, so it does spread easily. These do not have malignant potential unless they're co-infected with a high-risk strain. That's never been documented in the oral cavity, but that doesn't mean it can't happen. But having a condyloma in and of itself does not put the patient at an increased risk for HPV-driven oral cancer. I do point out which of these are sexually transmitted infections because it does matter. Because if my 6-year-old had a condyloma, I would be very concerned about that, but not any of these things. So here, here's a squamous papilloma. I'm going to give you several examples. So these are often pedunculated. They might be pebbly in architecture, or they might have these sort of frond-like wisps. So this is pretty classic. Here are some examples of verruca. You might find them clustered together because they are so contagious. And these are the common warts. So they can look like just little piles of skin, for lack of better terminology. And if the patient, especially a child, chews on these, it can spread to their oral cavity. So here we have a couple of verruca. This is a singular verruca. These do tend to be white because they do tend to produce a lot of keratin in the oral cavity. And verruca actually aren't that common in the oral cavity. Squamous papillomas, very common. Verruca, not so much. But here's what can happen if the patient's chewing on their warts. And now I have examples of condyloma acuminatum. So here is one of my patients. These tend to be clustered together and they're often described as fleshy. So they're skin colored. And here, this patient's biting on this one, so it's a little bit white, but this is how it is without the trauma. So clustered together, pebbly. These don't produce a lot of keratin, so mucosal colored, and they're characteristically described as fleshy. And then these are about 3 times the size of a squamous papilloma. So for example, condyloma acuminatum is not in the differential diagnosis for this. This is wispy, it's small, it's singular, but condylomata are very high on my list here and here and here. In fact, I can't think of anything else that could be. So my second to last thing I'm going to talk about is leukoplakia. This is the #1 way in which oral potentially malignant conditions present. It is most commonly noted in older adults. In fact, 10% of your white men over the age of 70 have leukoplakia. The most common location to find it is buccal mucosa and gingiva, but nearly all of those with dysplasia or cancer are found on the lateral ventral tongue or floor of mouth. Leukoplakia starts thin, roughly, this is a rough estimate, right? Gets thicker, then develops surface irregularities, and then it thins out again and starts to develop these red patches. And these lesions have sharply demarcated borders, and that's such an important sign for me, because if you're trying to determine, let's say, an occlusal lesion, is it frictional keratosis or leukoplakia? Well, if it's confined to the occlusion in an edentulous area and the borders are not sharply demarcated, it's probably just frictional keratosis. In general, thin leukoplakias are a lower grade dysplasia. As they get thicker, the dysplasia worsens. And then as it thins out and the red areas develop, by that time, it's almost always a high-grade dysplasia or a cancer. That all being said, the only way to tell is a biopsy. So if you have a patient with leukoplakia, biopsy is required. The differential diagnosis ranges from completely benign hyperkeratosis, some degree of dysplasia, all the way to squamous cell carcinoma. Treatment for leukoplakia. So leukoplakia is not a diagnosis, it's a clinical presentation. So we biopsy it, then we get our diagnosis. Once we have our diagnosis, then we know our treatment plan. If it's hyperkeratosis, our treatment plan is periodic follow-up. Recurrences or changes have to be rebiopsied because that means it's a new diagnosis. If it comes back as hyperkeratosis again, periodic follow-up. If it is mild dysplasia, there are two things you can do within the standard of care: destroy the lesion or watch the lesion. Especially with small lesions in patients with tobacco. It's okay to follow up in 3 months if they quit smoking. Sometimes that lesion will go away on its own, but I think it's better to destroy the lesion. The only thing we can do as dentists to lower the risk of malignant transformation in a patient with leukoplakia is destroy the tissue. It reduces the risk by 50%. Does not eliminate it, but it reduces it. Anyone with moderate dysplasia or worse, there's no opinion, there's no this or this, it has to be destroyed. So moderate dysplasia, severe dysplasia, carcinoma in situ, squamous cell carcinoma, all that tissue's got to go. And anyone with leukoplakia requires long-term follow-up. The literature says every 6 months for 20 years. So let me show you some examples of leukoplakia. Someone asked, if we see a patient is chewing on their cheek, do we have to biopsy that? And I would say no, because that's not true leukoplakia. So true leukoplakia means we don't know why it's there. So this for example, this patient isn't putting tobacco. I don't consider smokeless tobacco keratosis true leukoplakia because I know why it's there. So cheek chewing, I know why it's there. But this lesion, there's no other thing it could possibly be other than a white patch. So this is true leukoplakia. It's very sharply demarcated. You'll appreciate in these pictures, leukoplakia is often fissured. That requires biopsy. Here's another sharply demarcated lesion, non-smoker, non-drinker, still needs a biopsy. This was mild dysplasia. Very thin leukoplakia, but here's why we always still biopsy. This was carcinoma in situ. Here's a thicker leukoplakia. This was still just mild dysplasia. Here's a thicker leukoplakia. This is still just mild dysplasia. So white lesions aren't as advanced as red lesions in general. I put this picture in here because I want to caution you when the lesions are around the collar of a tooth. That's not good because we don't know what it's doing crawling down the crevicular epithelium. So this simple little white lesion right here was something that pathologists call atypical epithelial proliferation. And this is suggestive of either a squamous cell carcinoma or something that's going to be a squamous cell carcinoma. So this was a very advanced dysplasia, if not frank carcinoma. Here's another example, moderate dysplasia, very sharply demarcated lesion. These are a little tough. This is erythroleukoplakia. So this was severe dysplasia. So this is the time I often get asked about oral diagnostic aids. So like I said, Perel Pharma is sponsoring this. They make a product called Goggles. So that's an example of an oral diagnostic aid people use. There's also in the autofluorescence world, oral ID and Bellscope and things like that. So what you can do is look for the lesion, and then you can use your diagnostic adjunct like the Goggles and then look to make sure you didn't miss anything. That means you're looking twice. I would recommend against, let's say I see this lesion, don't use the aid to determine whether or not you're going to biopsy. If you see this lesion, you biopsy it. And this was severe dysplasia. This was severe dysplasia. So I can see, you know, the white part is what's sticking out to me, but it's the red that's bad. And this was severe dysplasia. And then the last little bit before I open it up for questions is squamous cell carcinoma. I just want to show you some pictures of HPV negative squamous cell carcinoma so your memory is refreshed. Your job is to see it and refer it. Most common locations, lateral ventral tongue, floor mouth, soft palate. But if you take anything home from this lecture, herpes on attached gingiva and hard palate, aphthous ulcers everywhere else, gingival carcinomas look like infections and reactive lesions. Be wary of unknown gingival lesions. Gingival cancers are like the bane of my existence. They are easily overlooked. It's very difficult to biopsy them and get a good diagnosis. So I want to especially point that out. So here's an exophytic squamous cell carcinoma in a person who'd smoked for a long time. This was a internal medicine physician who was aware of this lesion for 8 months before seeking treatment. Our PCP friends aren't taught a lot about oral path. So if you see a lesion like this, we don't refer to internal medicine, we refer to oral surgery. Any non-healing ulcer gets a biopsy, no exceptions. This was a squamous cell carcinoma. It was there for 18 months. This patient's only complaint was their denture wasn't fitting. Here is a cancer in an unusual location, very sharply demarcated. Remember to have your patient remove their dentures. This was a squamous cell carcinoma. You can see the rolled borders. So the rolled borders means the malignancy has dove into the tissue and is now moving laterally and pushing up those borders. Here is a squamous cell carcinoma that in hindsight, I can see the fullness of the gingiva, but might look like herpes or trauma. This was mistaken as a denture ulcer. This was a 17-year-old female, and this looks like a pyogenic granuloma, and it was a well-differentiated squamous cell carcinoma. That's why we biopsy these. Even small lesions, be wary of this in this location. Now you can get aphthous ulcers here, so you can palpate it to see if it's hard, but definitely keep an eye on that. And then some gingival carcinomas. So here's one that might not catch your eye, might look like periodontal disease. Here is sort of just, it kind of looks like a traumatic ulcer on the lateral tongue, but this was squamous cell carcinoma. And then here, one around the tooth, squamous cell carcinoma. So this was treated appropriately, but I've seen these be treated like perio disease, which I think is totally fine. Common things occur commonly. Perio disease happens commonly. But if it's not responding to appropriate therapy, especially on the gingiva, please take a biopsy. A couple other words I want to leave you with. Number one, women ages 18 to 44 for the past 20, 30 years have been getting tongue cancers at an increased rate of 0.6% per year. We don't know why. It's not HPV, it's not smoking. So please don't ignore your 20-something-year-old females with a lesion on their tongue, or males for that matter. I just had a 27-year-old male, and even if they were smoking, it didn't cause cancer at that age. No HPV, but had a tongue cancer. Can white lesions be confused with lichen planus? How do we tell the difference? Yes, they can be. Lichen planus should move and change patterns, migrate and change patterns. Leukoplakia does not move. So lichen planus will migrate and change patterns. Leukoplakia won't. That's a great question, especially if you're trying to tell the difference between proliferative verrucous leukoplakia and lichen planus. Is it true frictional trauma or repetitive cheek chewing can put you at risk for getting cancer? There have been some studies that have shown that. I think the risk is incredibly low. I do not consider cheek chewing to be a potentially malignant condition. How do you destroy the lesion of leukoplakia? I personally refer to oral surgery to take care of that for me, and they either use a laser or they take a scalpel and cut it all out. The percentage of smoking or dipping with oral cancer. About 80% of patients with oral cancer smoke cigarettes. The risk is actually very low with people who dip. It's actually not even statistically significantly higher, unless you have someone who's been doing it for years and years and years. Can I go, let's see. Piercings, there's no evidence those can increase cancer risk. 85% of all head and neck cancer caused by HPV. Okay, so is that true? About 85% of all oropharyngeal cancer is caused by HPV. And HPV-driven cancers constitute, it has been predicted that HPV-driven cancers will constitute over half of head and neck cancers by the year 2030. Let's see, how do I differentiate between verrucous carcinoma and papilloma or even condyloma? Great question. The only way is to biopsy. To manage thrush on an infant, I've actually published on this. There's not a lot of good protocols, but you can look this up. It's a liquid you put in their mouth. It's like a 0.5 milliliter. I forget the name of it. It's probably a nystatin or something like that. But yeah, you have to look into it, or actually email me that question and I'll email you the research. Does covering herpes with Vaseline help prevent them from spreading? I would not bet on it. So I wouldn't cover herpes with Vaseline in my dental office and continue to treat. Can patients with Crohn have recurrent aphthous ulcers? And absolutely they can. And in fact, that's one systemic cause of aphthous ulcers. Let's see. I'm not seeing any other. I'm rapid fire answering these questions so I can get to all of them. Can vaping or marijuana use increase risk for oral cancer? It has been well documented that marijuana use can increase risk for HPV-driven cancers because the marijuana makes it harder for your body to fight that virus. As far as vaping, there's been no studies saying it increases risk for oral cancer. However, it's only been around for about 10 years. And it takes about 20 years of smoking cigarettes for you to be considered at an increased risk for cancers. So the answer is not that we know of yet. How effective are HPV vaccines? Do I recommend? 1000% I recommend them. The immunization practices recommends boys and girls be vaccinated between the ages of 11 and 12. Very important to get them before age of sexual debut. It's a Gardasil 9 shot now. So it's protected against condylomata and 7 strains of oral and cervical cancer. More men get HPV-driven cancer than women. So men are getting throat cancer at a higher rate than women are getting cervical cancer. So it's actually more important to vaccinate boys. Both my sons will be getting them at age 11. They have about a 98% effectiveness. Do I see pathology in pediatric patients? Yes, I have whole lectures on that. So if you want to email me, I'll just send you my PowerPoint. How many days do I give the medication for prophylactic herpetic treatment? So let's say they're going on a beach vacation for 7 days. I will give them 7 days worth. You can give them 8 or 9 if you want to. Let's see. Sunlight affect risk of oral cancer? Yes, it's a very well documented cause for lower lip cancer. Oral cancer only if you have like xeroderma pigmentosum or something. Let's see. The person who had the herpetic ulcer, can you just Facebook me and then I can answer that question, or send me an email? How do I tell patients they have herpes lesions that are active, they can't have hygiene appointment? So what I typically say is, hey, you've got a cold sore right now. It's caused by a virus. And if I accidentally burst that virus, it can spread to your eye. So I can't see you right now. Here is a prescription for prevention. So it's a great way to not make your patients angry if you need to reschedule, but you or the doctor can prescribe them that valsiclovir or acyclovir preventative medication. Great practice builder. Give them a couple of refills because they're going to get 1 to 2 per year. It is $7.59. If you have any other questions, please contact me. People do it all day, every day. I love answering emails. I'm also on Facebook. If you want to find me, it's Ashley Clark. Or I think it's at Oral Pathology Speaker is my official Facebook page. If you want a free biopsy kit, contact me. But yeah, thanks for having me.